Hello, everybody, and welcome to the podcast, Redesigning Normal. I'm your host, Andrew Southern, and today I'm joined by Wendy Morell, who is the Director of Operations at MainStreet Family Care, which is a practice of, this is urgent care, Wendy?
Urgent care and primary care.
Urgent care and primary care in rural Alabama and rural Georgia. Did I get that right?
Thank you so much for having me. Yes. Thank you so much.
Thanks, Wendy.
We're in rural Alabama and rural Georgia. We have 22 clinics between the two states, and we are expanding this year into other states and then further into the areas we're in right now. Amazing.
Well, we'll get into that. But first, could you tell us, the audience, a little bit about yourself and about how you came to work at MainStreet, and then a little bit more about MainStreet?
Sure. Yeah. So MainStreet started about 6 years ago with one clinic and then has quickly grown into 22 clinics.
Wow.
Like Andrew said, in rural Alabama, we have a couple suburban area locations that are niche Kid Street locations. So they're pediatric, urgent cares, and primary cares. I have a law degree and an MBA from the University of Alabama. So after I finished school, I was kind of looking for a good opportunity to use both of those skill sets. I was definitely more interested in the business side of things rather than the law side. I wasn't really interested in practicing law. And I met the CEO. He was recruiting from our program, and not a lot of employers, a lot of employers were like, we don't need an in-house counsel. And I was like, no, that's not what I want to do. Mm-hmm. I have, an alphabet behind my name. Maybe I'm just a letter collector, but, was really interested more in the operations management side of things and kind of getting to know all of the corporate business aspects. And we just really clicked. I actually didn't even start. I actually originally applied for an operations position, and they needed the vacancy filled sooner than I could get to it. So the CEO created a different position for me where I was kind of working with special projects between the operations team, and we have a tiny software development team. So liaisoning between the two and working with the CEO on designing new processes, workflows, coming up with new service ideas, and then everything that it took from the brainstorming of those ideas to implementing them across our company.
Wow.
So that's how I originally came to be with MainStreet, and I have been here for, 4.5 years. I love it. I love the culture we have, and just very passionate about growing this company.
Wow. So it's a 6-year-old company, and you've been with it for 4.5 years. So you've probably been through most of the growth, I imagine?
Yes, I would say when I was first interviewing, we had like 7 or 8 clinics. By the time I was hired, we had 11. And then we grew to 16 that first year I was there. And then we plateaued at 16 for a while. Okay. And then last year during COVID, we went through a private equity deal in which we were signing up for a lot of growth. So we added 5 more clinics last year. No, 6 more clinics now. We just opened another one a couple months ago. And so now we went from 16 to 22 during COVID.
Amazing. And are these new builds, or are you acquiring other urgent care companies and rebranding and applying your process?
They're all de novo. We have one acquisition, but even from the building, we typically build from the ground up. There have been couple. Yeah, there have been a couple. Actually, we recently redesigned a KFC, but typically we have like a cookie cutter formula of the structure that we build. We have another couple that are in strip centers. Those are 2 of our first clinics in Arab and Center, Alabama. But otherwise, we have one acquisition in Andalusia, Alabama. It was a booming primary care practice, and so we rebranded that. I think in the future we will look more towards some mergers or acquisitions, but right now we're sticking to the formula that works for us as we ramp up this crazy growth.
Amazing. And so now let's rewind to the near beginning of 2020.
Yes.
And what was your role sort of when the clock strike 12 on January 1st, 2020?
Yes. So I was director of business development, but it wasn't a sales position as most people think of that role title. I mean, really it was development of our business, if that makes sense. Because like I said, we were working with special projects and services. I worked very closely with the CEO, and I still do, and kind of our software development team. So we were coming up with new solutions. We were actually in progress of trying to implement a direct primary care solution, which I don't know if you're familiar with that model, but essentially, it's a criticism. Well, maybe not a criticism. It's a solution in response to the problems that health insurance gives people. You're paying these insane premiums, and then you still have to pay for the health care, and you have these crazy deductibles. And so direct primary care tries to cut out that middleman by exchanging the service from the healthcare provider to the patient with no in-between for payment. So you pay it's like Netflix for healthcare. You pay a monthly subscription, and it includes most all of your routine health care. Okay. And it doesn't include, like, if you were to get cancer or get in a car accident or anything like that, but just that normal, like, I need to go get my blood pressure checked, or I have diabetes and I need that maintained. All that sort of, like, routine oil changes and car washes of your body, it's going to take care of. So we were trying to implement that solution at the time. We were shifting to selling it to employers because it's a great benefit for employers to offer. And that's where we were kind of leaving off before everything changed.
So then it's like, what, February or March, and you start to see, I think everybody was sort of like reading stuff happening in China about this like virus.
Yeah, so we heard about it before the new year even, and our CEO is extremely plugged in. I don't think he ever sleeps ever. He had proactively ordered a bunch of PPE. Like, our company had a lot of PPE before this pandemic struck, and it was one of those situations where if nothing had happened, we would probably be screwed with this giant stockpile of gloves and gowns and masks. But I think that was, a calculated decision because it didn't seem like nothing was going to happen. And so before the new year even started, unbeknownst to most of the leadership team, our CEO had kind of stockpiled these orders for our company that we found out about.
Wow. Yeah, because I've spoken to people that had a hard time getting that, once it became clear that there was something coming over here, and then everybody tried to order at the same time, and then there was, of course, shortages. So you guys were ahead of the game without even knowing it because the CEO had just went and done that. I suppose the calculation would be, we'll probably use these gloves anyway. Maybe not some of the
in
shields
this time frame, right?
Smart.
And we actually wound up being able to donate some to, rural hospitals in need at certain points. We didn't expect it to last this long. I don't think we had a stockpile for regular usage the entire time. There were certain things that we didn't. And also because there wasn't that much known about how it spread or what PPE was required at the time. Like, isolation gowns were a huge one. Those crappy little paper gowns that people wear. And we were running really low on those at several points in the pandemic. They became really hard to get because there was at one point there was guidance you need to change it after every patient.
Right, which is a tremendous amount of waste and
tremendous. Yeah. Wow. And so we had a kind of a stockpile prepared there of PPE at the beginning of the year, but we were working on this other solution, kind of waiting. And as I mentioned before, I was pregnant. And so I was early in my pregnancy. 2020, I'd always planned to, I'm a huge planner. And so I was like, 2020, great year to have a baby. Very easy to calculate age for the rest of your life.
Right.
Count from 2020. It's very easy to remember. And everything was kind of like in my little type A plan, going along perfectly. I communicated in February to my boss that I was pregnant and I would be having a baby in August, and he was excited for me, and he also told me that he had thought about shifting me over into operations entirely rather than kind of working on these special initiatives. There was a vacancy at the time running operations in the company. The person had just left in January, and they hadn't filled it yet, and he told me he was thinking about that, and we just kind of came up with this plan. Like, this is perfect. We have, basically 2/3 of my pregnancy, and I can go through all the documentation we have, all the policies and protocols. I can go through our offsite training program, like really immerse myself. That can be my project. Like, that can be my job. for the next several months. And this is from a company, we were a lot of startup vibe energy, because we are still a young company and weren't used to getting that amount of time to devote to really carefully and thoughtfully going back and having the opportunity to redo and improve. So we were just so excited. And that first, or second weekend in March, I traveled to our offsite training in Andalusia, Alabama, woke up, went to training at 8 a.m, started getting a lot of calls. I think this was, March 15th or 16th. It was that weekend. And had to basically turn around and travel back to the office because it was just escalating that quickly.
Right. Just go home. And you're pregnant at the time and no one really knows what's going on. And right. So there's just
and
like
the
all
girl
this...
next to me in training who was one of our employees was like coughing and all of it, it's like the tensions are rising just even in those hours. And I'm just, can you maybe not sit next to me? Can you please put on a mask? It was nerve-wracking. At the time, there was very little known about, especially, pregnancy and the pandemic, and just, in general, there was a lot unknown at the time. It was very scary. Mm-hmm.
So your plan when you were moving into that role, I imagine, and I don't know that much about, that particular profession, but I do understand about expansion, and I would imagine, as you were saying, I'm sure you already have a handbook, right? A training handbook and a sort of like an opening handbook. Here's how we build a new one of these, right?
Yes.
But to have a chance to go back over that and really refine it and make it into version 3 or version 4 so that handbook is like, this is how we open new locations, right?
Yes.
And we're also going to implement this across all of our other locations. Like, this is the gold standard.
Yeah, like our company handbook, our training, we have a whole binder that we use in training. We have a whole video training system that's, for all of the different roles that we have working in clinical staff. So, we were like, this is a great opportunity. Training is such a time suck. We can go through all the video content, make all the updates, find out opportunities for improvement so that we can really get everything scalable, standardized. There were even just other assorted policies, making them prettier, kind of condensing them, combining them, reorganizing them, making sure that we identified gaps. Like, we still don't have a weather closure official written policy, which has been on my list for months, but just things like that to make the, daily operations of the company smoother and less reliant on the executive team.
What about your pandemic response handbook? Was that written?
No, I am the author of that.
Right.
Probably tons of different versions on my desktop because it was changing every day. We would write a policy, CDC would come out with something, we would spend all this time up late nights, weekends, trying to make it so that we could implement, safety things, but also, new services. It first started with PCR testing, right? And the testing supplies were very difficult to get. We have a great relationship with LabCorp, and we're able to get some swab supply through them. We had to check our swab supply every single day, try to be very aggressive with ordering, talking to our account managers about ordering. We had to establish a new relationship with another lab, Assurance Laboratories, which they really were aggressive and they killed it. They would be very interesting to speak with about, their tremendous growth, and not just in the region, but in the nation, handling these tests. And trying to keep our stock up because we would just run out of testing supplies. And these were the send-out labs at the time, and this was the only way you could get tested.
Right.
The results, normally with laboratory results, you only call the patient, at least in our line of business, right? This is urgent care. We'll send some, you come in, you think you have strep, you don't have strep, we send it out for culture, and maybe it's fine, and we'll just, we tell you, we'll call you if it's something that we need to change what we put you on, if it affects treatment. Well, now you have to call everybody, whether it's negative or not, which when you're seeing the kind of volumes that we see, it's like you're the next day expecting a lean staff to call 60, 70, 80, 90, 100 people with their lab results.
So actually, let's back up a little bit. So, okay, it's March, like mid-March. Things are looking weird. What happens to the practice?
So things, that first couple week, I would say like the next couple days, it just was ghost town.
Okay.
No one was coming out. And I think that the medical field across the board saw this. No one was going to their dentist appointments or whatever. And we were the same thing. Like you, I guess, had to be deathly ill to come to us. And we were very concerned. We were just like, we're going to have to lay people off. We are, I don't know what to do. And so at that point, I was appointed because I'm like in this limbo position, right, where I was going to work on all these back projects, and now there's more pressing needs. So I was like the pandemic coordinator. Well, my number gets to go everywhere. And at first it was supposed to be just like, oh, you coordinate projects to keep staff, productive. If they're not seeing any patients, we can think of other things they can catch up on.
Sure.
Deep cleanings of the clinics and, reorganizing some stuff in the clinics and, window washing and improving the graphics, things like that. Just because, we have them there, it's a good time to kind of reset our clinics and keep them energized, keep them employed. And that was kind of where it started. And that lasted like 2 weeks. I think 1.5 weeks. The very first week we had the projects. We had a whole agenda of each week we're going to focus on, organizing our prescriptions that we have in the clinic that we offer through pre-pack, kind of redoing the shelves of that. And we did like a half a week of spring cleaning, and the volumes just started climbing back up.
For tests. So somebody called you on some morning a week or two later and said, there's a line of people out here.
Yeah. Yeah, and good luck calling the clinics because the phones were ringing off the hook. At one point, one of our nurse practitioners didn't answer the phone for 2 minutes, and there were 127 missed calls.
So word was out that your clinics could do testing. Maybe not all clinics could. I don't know what the situation was.
All clinics could.
Okay.
And the only other place in town at the time, because we had been so aggressive getting testing supplies, I think was like the major hospital, UAB in Birmingham. People were driving to Birmingham from all over the state to get testing. I think that, probably in Mobile and the other metro areas, maybe there were other hospitals that had this, but people were driving to our rural locations to get testing.
I see. Right. From the city, maybe.
Yep.
Wow. Okay. So now you've become, I would imagine, a lot of the other things that people would come in for has fallen off or at least is not as prevalent.
Ghosted.
Disappeared?
Yes.
And now you are a testing facility across multiple locations for the foreseeable future.
Yes, it was scary for our staff because of the health implications of that. And they're like, that's not what I signed up for. But then also, you don't want to shift your business to something that's not sustainable. Like, if we're now remorphing our business into being known as just a COVID testing facility, which isn't what we were. We just happened to offer the service. We were like, when this goes away, what's left? It's going to, then there's going to be a huge adaptation to getting our normal services back and our normal patients back. So it was very nerve-wracking trying to figure out how to limit that and how to weigh that. And then also when our, regular patients came in, they're behind a line of 43 COVID testing patients. What do you do with the guy who's coming for stitches?
Sure. Yeah.
Prioritize
Definitely.
him, or are you like, well, early bird gets the worm, so you're going to have to wait.
The only benefit, and there's very difficult to find, benefits here, is that people in your communities are now aware that this clinic is there because they went there for a COVID test, and they may have in their mind, hey, I went to that clinic.
Right.
Maybe they waited in a long line, but at least they understood, like, there's this thing in my community where I could potentially go for other medical services when all of this is over. And of course, it's unclear when all of this is going to be over. I've spoken to people on the podcast, a lot of people who got the impression from the government or whatever, that this would be a 3-week slowdown in mid-March, right? And by April, we're probably back up and running again. And of course, that's not the case.
Yeah, that was the impression here.
Okay.
Definitely. Not with us. Like, our corporate team was not under a disillusion that
Okay.
was going to be the case, but that was what the communities were expressing.
see.
And so as we are offering this testing and volume is increasing, as you mentioned, we started getting calls and pictures of our clinics, people lining up, bringing lawn chairs. At first it was, our clinics opened at 8 a.m. So at first it was people lining up at 6 a.m. We're like, oh my gosh, people waiting 2 hours? This is crazy. And then it was just getting earlier. Now people are lining up at 3 a.m. Like 3 a.m. People are bringing, like, virtually camping out. It's like Best Buy or Walmart at Black Friday. And no one, like, we didn't communicate this. We didn't tell people this. We didn't give direction of this is what you should do. I mean, it creeped all the way back into midnight or before. And then also, I mean, that's a liability a little bit,
people
to have.
Yeah, sitting in your parking lot or on your sidewalk. Yeah.
Right.
Security and I don't know I guess the weather's temperate. And these are all people that are also there to get a test for some reason. They feel as though they may have been exposed. So there's a certain amount of distance that really should be between these people as they're waiting for this.
But, like, then we don't have people there traffic controlling that,
right.
There were a lot of questions throughout the pandemic, and I think there still are, about what responsibility do we have policing adults' behavior. Because
it's a big topic.
Yeah. I mean, you should know that you should stay 6 feet apart. We shouldn't have to tape down concrete, especially when we and also we don't want to encourage the lining up. So it's like, at what point do we implement rules and then make it seem like we're condoning it versus, what is our responsibility to try to protect people? We still get complaints about that with, the waiting room. It's very difficult to figure out how to space out your waiting room. I mean, we have a limit of how many people can be in our waiting room at one time.
Okay. Yep. But
it gets uncomfortable. You can't control you can't control if Susan is going to walk, within 12 inches or try to stand right next to you, sitting down. Like, how do you aggressively go up to, and I also see this in the supermarket all the time because it infuriates me. The supermarket has a mask policy. We as a city are still under mask regulation, but it's like not enforced. And I think that's because it's really uncomfortable to figure out how we, as people who are not law enforcement, can peacefully, regulate people's behavior in a way that doesn't seem divisive or aggressive.
Sure. It's very much like a social compact as well, because there are certain places or cultures which are maybe a bit more in tune with the sort of common good or the greater good. And that can be true. I mean, the U.S. is a very big place. And so the sort of individualism versus the sort of group think is different in different places. Because I've spent some time in New York and, everybody's got a mask until the CDC said it was okay to not have a mask. And then people brought their masks down. Whereas I know, because I've spoken to a bunch of people in a bunch of different places around the country, that even though the laws may be that you're supposed to do this, socially no one else is doing it. You would maybe feel even outcast if you were the one that was doing it.
To do it, right.
And so you don't want to be ostracized by your peers or what. I mean, there's a lot of that people will be pulling apart for years to come. But once they hit your facility, there are rules and regulations, particularly in a medical facility, that I think everybody understands they need to follow. And actually, that's the part I was going to ask you about. What did you, as the director of operations, maybe along with guidance from the CDC and the other executive team members, decide to do in the facilities in order to keep people safe and feeling comfortable in the facilities?
So like I said, we limited the number of people in the waiting room that they could call in at one time. People were required to wear masks. We were cleaning down as people were, getting up from sitting down, which is all hygiene theater. Now that, we're on the other side of the realization of what was actually making a difference and what was not. Along with PPE, we had to kind of stockpile a little bit of cleaning supplies as well. So, counter wipe downs. We did wiping of the pens, after people use them. We had clean and
dirty. Yeah.
Yes. And with the iPad that we have people take a survey on as they're going out the door, which is an important metric and, KPI for us. The iPad, we had to wipe it down. People were really afraid to touch the iPad, so that was a whole nother set of things. But it was really funny because, people would be afraid to touch the iPad with their finger to just press a number, but then they would open the door to go out.
Sure. Of course.
It was a lot of interesting human behavior. Yeah, and then, of course, generally speaking, in regards to other cleaning and things like that, when you're a medical facility, you're doing that anyway. You're cleaning the exam rooms after every patient. And similarly with the waiting room, we amped it up a lot, but when you're getting sick patients, you're going to want to keep that frequently clean throughout the day as well. It's just
Did you do bit. Temperature checks and check-ins and
Well, we didn't do temperature checks because you're there because you're sick. You get triaged when you are checked in, and so you get your temperature checked at that time, but what would we do if we checked temperature and someone had a fever? We would be like, sure, you're in the right place.
Right.
Welcome.
Understood. Understood.
Yeah.
I've spoken to some places like restaurants and other places that implemented air filtration, for instance, other things did you guys end up doing that, or maybe that was already built in?
Yeah, we did not. In regards to our staff, they were wearing so much PPE, and then we did temperature check them twice a day. They're supposed to check temperature check in the morning and the evening, and we definitely caught some fevers that way. But no, we didn't do the filtration, and maybe that's something we have in mind for the future. But at the time, everyone is sick in there, and I think we had consulted with somebody who was seeing if it would be effective for us, just based on the time that people are in there, because they come in, they check in, then they go wait in their cars, and they come back in and to be seen, and then they have their mask on unless they're getting swabbed or something like that. And so that's not something that we've invested in right now, but not something I would eliminate thought of in the future.
Got it. Now, during the sort of testing work time, I've gotten some tests. I'm sure you've gotten a couple tests as well.
Yes.
PCR, I guess, in the beginning went really far up your nose. Maybe it doesn't need to go as far up. There's a couple different flavors. And then there's the rapid testing. And then my friend in Miami was telling me that there's a saliva test that someone can run. I don't know if that's true. Maybe that's just a rapid test.
There is now. I think that is a rapid. You can also mail that out, I believe. But this is one of my favorite misconceptions to clear up. And I feel like I was a Facebook fiend when I was clearing up these misconceptions last year between the different kinds of tests. Because you're right, the brain tickle one, so that's nasopharyngeal. And so that was the first kind of test available. And that was they were saying maybe the preferred sample. Well, at the same time, that was what most clinics were doing. There was also oropharyngeal, which is basically deep in the back of your throat,
right.
Oro, naso.
Which, by the way, I can't do. Just for the record, I can't do it. Strep throat test, can't do a strep throat test. I can do the nose uncomfortably.
I would much rather the throat. The nose, my eyes water for a long, long time after. It gives you that shiver kind of.
It does. But the other one, I can't. I will walk out of the clinic and be like, I'm sorry. Assume I have strep.
we had a couple people like that were just like, can you do the nose one? Because they really didn't want to do it. But so we were doing the one in the mouth, and I think we also gained a good reputation. You don't like that, but a lot of people were very afraid of the, swab, I don't know, tickling their brain. And so we were good. For most people, not Andrew Southern, but other people in the community wanted that. And so that was what we were primarily doing. And then there is a third option that became available later in the pandemic. I can't remember the exact timeline, but that was nasal. So the nasal is more what's common now in the nose, where you just have to go in within the first inch of the nostril. And so it's much less steep. And that was what we shifted to. It was also always a gamble because we were doing the oropharyngeal at first, and we stocked up on those. And then we were kind of running out. We had previously been able to always kind of try to, by the skin of our neck, get more. And then we were only able to get the naso. And so we shifted to that. And then the nasal came out. And it was, every time we did a change, we had to roll out a training change. Sure. Okay, now we're collecting this way. Because also the swabs are all swabs. They look so similar. And also, because of the supply chain issues, they were coming from 19,000 different vendors. Mm-hmm. And so it's not necessarily like, oh, and this one is always a green top, and this one is always a yellow top. Like, they look different. This one comes from China. This one's coming from Italy. And the directions are like IKEA assembly instructions, and we had to roll out different training and different communication every time we switch. So that's why we tried to avoid the switching frictions and tried to stick with one method. And we resisted the nasal for a while because we had been doing the oro, and then we had to switch back to the nasopharyngeal, and then we went back to the oro. Then they were trying to switch us to the nasal. We were very resistant. We're like, we can't change methods. It's like so much work every time we do this. But we knew at some point it would, find a happy place and find the one that was sustainable. And it wound up kind of being the nasal. So we, after a couple weeks of resistance, when we were really running out of supply, we made the switch over to nasal, and that's kind of where we've stayed because that's the short one. That's the one that only goes a little bit up. But you can run a PCR on that sample or a rapid nasal on that same sample type. Yes. So yes, then rapids, we were actually very, very aggressive throughout this interview. I'm like, we're just very aggressive. It's an aggressive practice. We're aggressive people. We were the first, or one of the first, to get rapid testing. We were on the list before the machines were even released. And so, again, people driving from city areas, like you were saying, to rural areas to get rapid tested. And then, of course, we still have the PCR test because if someone is symptomatic, well, first, if someone requests it, we're going to send it. And then if someone is symptomatic but gets a negative on the rapid, it's possible that, their level is not yet high enough to show up on the rapid, and so we would send that out for a confirmation test. So then word quickly spread that we had rapids, and it just it exploded our volume, but it also solved a lot of frictions for us because at that point we were seeing, over 100 patients per day or near 100. And these are facilities that typically, like 45, 50 is a busy, booming day, for these 3-people teams. And now they're seeing this amount. And so we had really had a backlog of results that we were really trying to get all hands on deck to, because like I said, you have to call the negative patients, and then not only that, but you have to have a way to they all need a copy of their results, which is again,
like a portal or something, like a web portal. Wow. Yeah,
so we had to develop one of those.
I thought maybe the lab might have the portal with a login that you could give them a card and say, this is your, go to the lab.
So LabCorp does have a portal that you can go look up. There are just a lot of people frictions there. Patients just don't get it.
Got it. Yeah.
It's very difficult. You really want to establish, and also a lot of patients need it printed out, and they don't have access to the internet. They're in these rural areas, and so they want somebody to call them and give them to them, and they need it printed out. They need to bring it to work. So at some point in the summer, as I have a full-blown human growing inside me, ripping apart my hip bone as I'm working, 15-hour days, we got our software development team to create a web registration system.
Right.
And simultaneously, we were having people sign into a patient portal that we had for our primary care patients previously. It's like not everyone was signing up because you can message back and forth. It just becomes a huge, resource suck for everyone to be able to have access to it. But we were having everybody who got tested register for the portal so we could message them their results. Mm-hmm. That would be great, but there are other frictions with outside labs that were causing a tremendous delay in communicating those results to us.
I see.
So the way that our portal was set up, it didn't have a lab interface integration like our EMR does. This was a separate portal. And so the way that results were communicated there, they were faxed in. E-fax, it's like basically an email, secure. And that's how we always received kind of lab results before for that portal. But the lab's fax system, because they were processing so many, it just got bigger and bigger and bigger. So there would be days lag between when the fax was put in the queue to get sent out and then when it actually got sent out. And patients were, calling us. And so, where are our results? But we don't have them yet. And, then they would get the lab result and see that it was processed 6 days ago, but we just got it today. The fax just came through today. There was a lot of handling that with the labs, trying to figure out how they can get their queues caught up and why is this, happening.
Wow.
You wouldn't think that would happen with something digital. If you send 20 emails in a row, like you're not expecting the 20th email to be sent 3 hours later.
No.
But that's what was, yeah. So they were sending thousands, tens of thousands out, and that's what it was doing. It was just the system could only process them so quickly.
And then once you would get them, then somebody would basically take that email and attach it to the record, securely attach it to the record. And then that record is available for the person to go into the portal and see.
Yes.
Okay.
But and also you're having to have, like, this is a lab result. You have to have a medical professional review it because, and then if it's positive, you definitely need to call them and then you need to report it. Which the lab also reports positives to the CDC. So that's a redundancy that seems very unnecessary to me.
Does that double the response? Like, does that double the positives?
No, it doesn't double the positives. It doesn't double the record because you're reporting the same patient information and they have a system that resolves those duplicates. But so actually, in fact, if the lab will report the positive when they process it, and then the provider is expected to also report the positive. And then if the provider doesn't, the CDC calls and it's like, why haven't you reported this positive yet? And you're like, why did I need to report the positive if you already know about it?
Sure.
Like, this seems like a huge time suck for, this resource that we have to both send that positive in. It's just a lot of rules.
That's
like
very
that
confusing.
Mm-hmm.
So
especially when it takes 6 days for us to get the results. We're like, well, we didn't get them yet. This is news to me that this patient's positive.
Hopefully that's all chilled out a little bit now.
It has definitely chilled. And like I was saying, the rapids have helped with that because now you have results when you're there in the clinic, and it just alleviated the circus of results.
Sure. And those, I understand, the lab you guys became a rapid testing lab at the facility, right? With a machine that does that. So those results do need to be directly reported because you are the lab.
Yep.
That makes sense.
And we do. Yep. There's a nice little CSV that we upload every day.
I know that you're not just doing testing anymore. I'm sure that you're seeing patients again, which is great, and sort of transitioning hopefully back into normal practice or semi-normal, redesigned normal.
Yeah.
Was the testing, was the money coming in from testing, whether that's, I don't know if the government's giving you some money to do that or whether the patients are giving you, was that enough to sort of maintain your various locations and everyone still got paid? Or did you have to take a hit? What happened to the practice?
So in the beginning, we were very aggressive, again, with PPP, filing for that. Our CFO, Rep Pluggy, was extremely, devoting a lot of energy to that. And we were awarded that, and so we were able to keep staff. So that was when volumes were dipping, and we were concerned about having to let people go. So we didn't have to let anyone go, which was really good because a lot of people preemptively let people go, and then volume exploded in these kinds of practices, and then they didn't have the staff or trained staff to be able to resume because they had not even just furloughed, they fully let people go. And also remember too, this was in March, so our business is somewhat seasonal, and March is typically the decline of flu season. And so we do have seasonal staff that we typically, lay off during that springtime. And I think that was kind of, a lot of urgent care businesses saw that as like, oh, well, this kind of coincides with when we would lay people off anyway. And so it kind of all just lines up. But fortunately, we were able to get PPP. We were able to keep everyone employed, which was amazing and just a huge relief because we
Sure.
really care about the people who work for us, and it was just a huge relief to be able to provide normal hours and be able to pay them. But the revenue stream from testing and vaccines and all the different kinds of testing that are available now, in the beginning, I mean, we were offering testing and people were asking how much would it cost, and we just don't know. Like every service was released with reimbursement as an afterthought. And so it was released and it was like a big push, do this, do this, do this. But then we weren't able to answer questions like that. And also we're not really fully responsible for questions like you need to consult your insurance. You need to figure out how quickly your insurance is going to take it. We did, we were also one of the first people registered for the uninsured portal that the government was offering, which was, this fund. And we thought it wouldn't last very long, but then it kept getting funded. And coincidentally, the fund pays for these tests, reimburses us for the tests at a better rate than most every insurance. So, but in the beginning, we didn't know how are we going to get reimbursed for these visits. There were no, typically with services, there's a negotiated rate between the provider and the health insurance or, Medicaid or Medicare, and all these rates are kind of established. So this is the cost of the test. This is like how many extra people we're going to have to hire to administer it. And then this is how many each person would bring in. So you can make that calculation. How many patients do we need to make it profitable for us to offer the service? But that all came after. So, and to be, quite honest, especially with the asymptomatic exposure patients, they're not super profitable. And definitely we're pouring a lot of executive and leadership resource and ancillary resource into offering that. And we just it was our ethical duty. Like, of course, the volume is good and it keeps our clinics going. And we knew that eventually the reimbursement would figure itself out and we would get some sort of compensation for the visits. But just ethically, we knew that since we had the ability to do it and we had the locations to do it, it was our responsibility for, sounds like noble or something, but it was just like, we just had to do it.
This is actually a responsibility that extends across the entire healthcare world, right? That I felt like, healthcare people are heroes and always have been, and now we're starting to get recognized. Like your entire team, your entire staff, when it's very unclear what's happening in April. It's very unclear. Like I don't know if I'm supposed to wipe down my milk.
Groceries, great.
Right. But your team are still showing up to work to literally test people who think they have COVID, which is amazing. And I wouldn't have put it past anyone to just be like, I'm tapping out of this. Like, I don't want to do this. Right?
And I do, I just have to give tremendous kudos and accolades to our staff across all of our clinics. Especially, we are primarily female driven clinical staff workforce. We had a lot of pregnant medical assistants and nurse practitioners. We had, a lot of high risk people seeing these patients. And as I was telling you earlier, they're in this tunnel. They've been in this tunnel with a, promised light at the end for over a year now. And the positive attitudes and just like the energy and drive of knowing that they are helping the community. And this is kind of, something that they have taken on in their profession, and this is why they're here and they want to help people. And I just have to give tremendous props to them because they're awesome. And we're just so grateful to have staff that has positive attitude and is working so hard. They shouldn't have to work this hard, but, and we hope that they get a breather soon, but it's been, amazing and inspiring to watch people help other people so selflessly during a really, really scary time.
Are you guys now administering vaccines for COVID-19?
We are.
So it's like the testing goes down and then the appointments for this go up?
Yes. So as our CMO said, vaccines were the final kick of 2020. We got vaccine stock 2 days before Christmas.
Wow.
And like with everything, there was not, everything is like, you don't know. Okay, something's coming tomorrow. You don't know. Okay, the rapid machines are coming tomorrow. And it's, you have to, now you can't prepare, or you can only prepare so much until you have it in hand.
Sure.
And this goes for, all the kind of services along the way. Vaccines came a couple days before Christmas. We were just, of course they did. Of course they came a couple days before the holiday. We actually were given Pfizer first. We applied for both. Just the way that you apply to get the stock was a little disorganized. And we were awarded both. But we were notified of Pfizer first, which had all these extreme storage parameters at the time. So 2 days before Christmas, we are calling dry ice vendors because we don't have super cold storage, but we were like, well, we had the deep freezers and we figured out a way, like you could keep it on dry ice and exchange the dry ice every 5 days. And we were like, well, if this is all we can get, like our communities need these and we're going to put in extra time and energy to make sure that we can safely store them. But then it's 2 days before Christmas. So none of these vendors are answering the phone.
Sure.
And of course. And so the way that they were shipped in, and the way the calendar worked out, we were very nervous because there were going to be a couple days in there, Christmas Day, we weren't going to be able to administer any. Christmas Eve, we wound up giving our staff off because the year was a whole year. And we just knew that there would be those couple days. It only lasted 5 days on the dry ice. We weren't able to get in touch with any vendors. So then we start trying to figure out who we can give these vaccines to that has super cold storage. And so the day before Christmas Eve, that's kind of what we were doing in the morning. And then we received a subsequent email that we were also receiving Moderna.
Okay.
And so we were like, well, we have Moderna now, so we really don't need these Pfizer. It didn't seem as dire to like figure out a way to keep them because we knew that we would have the Moderna stock. We did eventually, a pharmacist in a nearby area drove and picked up the Pfizer Christmas Eve morning. I got a call at 6 a.m. that they were coming by one of the clinics to pick up the stock. Could we have it ready for them? And so we did, and we got Moderna and started offering it there. And I am very pro-vaccine, and I have the vaccine. I am very, very excited that it's available. The rollout was frustrating, not just for our company, but I think for the country, because the limitations that the vaccine has on how it can be operationalized are complicated. Right. It's not Johnson & Johnson, which then didn't that turn a little complicated? Yeah. Where it's just one and done, you come in, you get the vaccine. It is 10 doses per vial. You can only keep the vial 6 hours after you first puncture it. So from the first dose you have 6 hours to get rid of the other 9 doses. Then, of course, you have a second dose you have to get in a certain time frame. And also, as a wonderful bonus complicating factor, some of the vials have 11 or 12 doses. Mm-hmm. Do you throw those away? Right. Or do you administer them? Because then the complementary vial you're going to get for that first vial that had 11 or 12 doses has 10 doses. So now for the first one vial, you're going to need 2 vials. Mm-hmm. And so these are really complicated, not easy to answer questions, especially for smaller practices. And when any practice or facility is just given these with these kinds of parameters and expected to quickly roll them out, some guidance or instruction would be helpful, figuring out how to minimize waste. Sure. And how to, and also just like the expectation that it's on private practices to figure out and spend resource and time. And like, again, kind of like the other testing, like these aren't money makers. We're billing a very nominal fee for the administration of the vaccine. And then we're not charging for the vaccine because that came for free. We actually have spent our own money on the resources, the needles and things like that for the vaccine, because the ancillary supplies they come with are not high quality. And we had a lot of complaints from staff that they're just cheap. They're cheap. They're ancillary supplies that are for free. And so we spent our own time and money ordering what we would normally order for administration of something like that, but we're not billing for that. And so again, this isn't like super lucrative, and are spending a lot of leadership energy into trying to figure out, okay, you need to know from the day one when that person's coming back, when to tell them to come back for their second dose. And initially, some other places were giving people, a range of days, and we were very reluctant to do that because we were thinking this isn't going to match up. Like, every person that comes out of this vial needs to come back on the same day, because if you have one exception, you have 10 doses and you administer. And then Susan has chemotherapy and her doctor wants her to get it 1 week later than she's supposed to. These are like, this really happened to us. We have patients who, were on chemo and their doctors wanted it to come days late. Okay, so now you have 9 coming back for that vial. What do you do with that one extra dose? Do you give it to somebody as a first dose? Because they're not promised a second dose. Do you throw it away? Do you try to find another second dose person to come on that day? Because then you're pulling one from their vial. And then now Susan, the chemotherapy patient, who we feel very sorry for, and we want to do everything to accommodate her because we want her to be vaccinated and stay healthy and see her grandkids. We've moved her. Now there are 11 on that day. So now you need to open 2 vials that day for second doses. And what do you do with the 9?
Yeah, of course.
It's just it's so cyclical. Yeah. So I think that and another parameter was that probably isn't so bad if you have a continuous stock coming in of vaccines, because if you have a consistent supply, then when you move Susan and she's taking up the first dose of that other vial, you're of course going to give the 9, as first doses, because it's all just going to come out in the wash. You're just going to fill up the days as they come along. You'll fill up the days with the second doses that are due. And also you're assuming everyone's showing up, which doesn't happen.
Doesn't happen.
Right. And so, but then you just, give the second doses their opportunity to come, and then you kind of, toward the end of the day, I'm sure you maybe have had friends or talked to people who go toward the end of the day at a facility and they have extra vaccine and they get it that way. Yeah. And it's just very complicated. I mean, and it's not just complicated from, an operational standpoint. It's complicated from an ethical standpoint. Like, do I want the blood on my hands from throwing 9 doses away, or even throwing 2 doses away?
There's also like an undercurrent of, I don't know what the percentage is, of people who are not only not going to get the vaccine, but are like anti-vaccine. Yes. And I don't know if you saw this like in California. I hope you didn't see this at any of your clinics, where people are like out there like saying, oh, the vaccine and 5G are what's going to control us. Right.
The chip.
The chip. Did you have any of that?
The chip.
Did you have any of that business going on?
We didn't. Fortunately. I mean, we've had people deny and probably say some side comments, but you're already chipped and it's in your phone. So I just hope that everyone recognizes that it's fine that you're already chipped. You're carrying it around every day.
You bought it, right? You bought the chip.
You bought it. You purchased the chip. You volunteered for the chip. And it's actually not doing you as good as the vaccine is going to do. So no, we fortunately, but throughout the pandemic, we had staff deal with a lot of threats, like a lot of threatening patients about, if they arrived too late. And so we wound up implementing, like I said, a web registration system. And along with that, we had to design an algorithm that would figure out a cap for the day of how many patients they could see. And so depending on staffing, they started with a certain cap. And then throughout the afternoon, the system looked at how many were still in the queue to be seen. So it kind of figured out the rate of how they were being seen. Because it's also going to vary, especially, an asymptomatic patient coming in just because their neighbor had it, but they're not experiencing. They're basically just coming in for a test. Versus someone who's symptomatic coming in, you have to evaluate, like, do they need, how serious this is? We need to get an x-ray, all this stuff. So it just depends on the distribution of patient complication, how fast they're going to go. So the system would look and see how many were still in the queue, and then see how many hours were left in the day, and figure out if they could open registration back up if it was full. basically when to cut it off each time. So it would evaluate it as the day goes on, and maybe more spots would open up or maybe no more would open up, just depending on how the day was progressing. And staff would get people who came in and they had reached their limit for the day. They were already going to get out an hour late or something, and just threaten their lives and their families, and were called terrible names when these people are being very patient and giving of their health and their time and their resource, giving up time with their families, trying to arrange childcare when there's no school or childcare open, and they're there to help people, and then they get this person just blasting in their... We had people cough on our staff on purpose, like, I hope you get COVID, and spitting and coughing in their face. So we've had to hang signs, just like, be nice to our staff. Like, I just want to hang a huge poster that's just like, can you be a decent human being, please?
Sure.
Of course, we have patients that are like overwhelmingly, grateful. And we've had patients buy lunch for the staff, just like, I saw how patient and wonderful they've been, and this is so hard. Here's some money to get lunch. So that's good, but
the other side is that you've got people
being terrible.
I hope that didn't happen often. I hope that was very rare, because that sounds terrible.
Yeah, I don't think it was as rare as you would think or we would like, sadly. I think that these things bring out the extremes in humanity, and that's sad. And and as we talk to people, about this, and they just had they're like, well, I just feel sorry for that person because they must have a really terrible life. But I think that spreads across. I mean, that goes outside the pandemic. Just any service, person, or really anybody, just be a nice person and treat other people with respect, and it'll make your life better and happier. Not to go on like be kind tangent, but
this story has got everything. It's got it's got drama and aggressiveness, and it's got
babies.
It's got babies. It's got bad people. It's got incredible acts of kindness and heroic bravery. Right? It's got money and loss and growth, and it's pretty amazing.
Yeah. So during this time period, we went through a deal with a private equity firm. We grew 6 more clinics. We have plans to grow 12 to 15 clinics for the next 4 or 5 years. Each year, 12 or 15 clinics.
Wow.
So we're just, not taking a break. And we still, honestly, some of our clinics have slowed down, but we still are seeing upwards of 60 patients now in our clinics. So staff is still just incredibly busy.
Wow.
And I think that it's from our patient distribution that we've seen, it used to be a lot of asymptomatic exposure patients. It's now gone back to a variety, first of all, not just testing patients. We see injuries and other sorts of illnesses, but now the people who come in, they are experienced and they want to be tested. It tends to be more symptomatic, like they're sick.
Or people are going to travel and they need a PCR test. That would be the other thing, right? Because I've had to go in and do that a couple times.
Yes.
Wow, that's an amazing story. The last question I wanted to ask was, as you guys are expanding your footprint, are you going to be going into other states or other regions of the states that you're in already in Alabama and Georgia?
Yes. So we don't have any more plans for Alabama expansion. We have 17 clinics throughout the state of Alabama right now. And we have 5 in Georgia. And so we're planning on expanding in Georgia, definitely. Florida is on the horizon. North Carolina is on the horizon, maybe South Carolina. So
wow.
Yep. So I'm from the New Orleans area, and I keep trying to push that, but there are no bites.
Have you been to all of these sites? Have you had to go there as the director of operations and actually see each place?
Yeah. So when I was working in my previous position, I would frequently go to, not super frequently, but not irregularly go to the 16 locations we had at the time around Alabama. And then last year, as we were building, when I was pregnant, I went to our groundbreaking for our Bainbridge, Georgia location at the time. And then once the other locations were opening, it was just, I was getting too late in pregnancy to and also COVID, I was supposed to isolate for the couple weeks before I was due, which very considerate of her. She was naturally born on her due date. So, very fitting with my type A schedule planning. She really got the message. She was due on a Friday, and I was planning on, everyone goes over on their first baby past their due date. And I was like, really going to have that one last weekend. And
right.
Just did not get it. But yes, so typically we go and travel. And so, it's a little bit difficult now still because of daycare parameters of when you can drop off and pick up due to COVID. And then I'm also breastfeeding. So there's that fun element as well. But yeah, typically we go around and we travel. I think that, as we grow, it may become less common, and especially we grow and we're getting farther and farther away. It's not super feasible
of course.
to visit all the time. But we have a pair of regional managers, Amanda Goebel and Leah Rayburn, for the different regions. So they each manage about 10 or 11 clinics. And so they are a presence in the clinic. And then we have some frontline managers that each manage about 3 clinics each. So
got it.
That's our management presence. Yeah, it's the windshield time is such a suck, especially when you have these clinics that are like 6 hours drive away from you. And I would love to be there all the time, but the windshield time just is a real time killer.
You need the MainStreet jet. That's the way to do it.
I've been pushing that.
Come on, executive team. We're getting there.
I know. We keep making comments, but we have little, we call them Wags mobiles. Our mascot is a doctor dog called Dr. Wags. And we call them Wags mobiles because they're just covered in these obnoxious graphics. And by obnoxious, I mean that very lovingly.
Sure.
About MainStreet Family Care and Dr. Wags on there. So they're these little Chevy Spark cars. That you can drive around, and they get great gas mileage. Not exactly a family car; they're like little 2-door, vehicles. So typically, when we travel, we go along that, and that's what we need. We just need a Wags jet.
If you can put the logo, it will be a lot less obnoxious if it's just on the side of a jet.
If it's in the sky, it's less obnoxious. Yes.
Okay, I think we've really cracked the code here.
Right.
Well, Wendy, I want to thank you so much for being on the show. This has been such an amazing story, and it sounds like you've had a lot of success, actually, during this terrible time. A lot of things have been done well and have resulted in the communities that you serve being well served.
Yeah, we've definitely grown along the way. Web registration that we developed is never going to go away. That's just how we register patients now. And, we've really shifted more toward the texting of the patients. We got a whole text system going. And so all of those sort of digital communication methods that we have with patients, it really was a good push to quickly implement and kind of get those going. They were always things that we had on the horizon, but now that was a good opportunity to just really, push the issue and get us to go ahead and figure it out and implement it under a lot of stress. And so I know that they weren't for temporary solutions. They're here and they're still helping us, and we're just going to use them and improve them going forward.
Amazing. The whole story is amazing. Thank you very much.
Wait, I had a baby, and her name was Louise, and she's very beautiful, and she was born August 7th, and she is super, super cute, and she is a leader already.
Awesome. Well,
she's redesigned my normal for sure. in good ways and in bad ways.
So wait, how old is she now?
She is 9 months today.
Oh, congratulations.
Yeah.
So she's crawling around. She's where are we at with the baby development?
She just started. Yeah, you're right there. Yeah, she's mobile, and she just has found direction with her mobility in the past week or two.
Right.
And daycare told me yesterday she needs to start. Actually, we call it work. She goes to work. She that's where she goes. She has 2 supervisors. Very serious. Corner office. They told me yesterday that she has to start wearing shoes. She can't wear any more little baby jammies because she is standing up all the time, and they don't want her to slip. So she's like a real little human.
This is the period of time when once they become mobile and can head for the stairs.
Yes.
That now it gets a bit more complicated because now you have to start thinking about cordoning off parts of your house and the outlets and stuff like that.
Yeah, we invested in gates a couple weeks ago because we saw it coming. She was rocking, and we knew it was right around the corner.
Yeah, you're right on time. I've been through this a couple times, but it's been a long time, and I think that baby technology like changes tremendously over time.
Yes.
And so the tools that you have available to you, the gates you can buy, and all this stuff, it's way better than this stuff. We had bamboo. No, I'm kidding.
Just empty Amazon boxes just piled in the doorway. Yeah, well, I had to give props to. I mean, it was just such a crazy year, and she changed my life for sure, trying to figure out a new normal for navigating work and motherhood and the pandemic. And so I think I also just want to give support and props to like everyone who's had a baby during this time, because whenever I see somebody who is walking around with a baby, I feel like we were on the Titanic together. Just feel like a sense of kinship, because no one else can really understand the incredible stress and, uncertainty and joy of all of that, fellow COVID baby hatchers.
Yeah, it was a difficult time, and that period of time, I mean, I haven't experienced it myself, but as a partner of somebody who's had 2 babies, it's already a stressful time. Where it's sort of filled with uncertainty, right? Mm-hmm. It can be very exciting, but it's also filled with uncertainty. And then you've got this other thing on top of a pandemic that happens once every 100 years, right? So it's not going to happen again, hopefully.
Yeah.
And the 2 stresses on top, and you also want to create an environment where the baby comes out into a happy, hopeful place.
Mm-hmm. Yep. Yeah, I've worked for forever, since I was 14. Never had a break. I'm just, type A, super go-getter, and not my whole life, not like a kindergartner dreaming of maternity leave, but since I've had thoughts of a family, I'm like, oh, maternity leave. I'm going to have an Aperol spritz on the patio with my baby. I'm going to have lunch with my friends. It's going to be such a breath of fresh air. Not that it wouldn't be hard. Maternity leave is a lot of work, but just to have that one focus and not have, 3 different projects or jobs that I'm being pulled in different directions. And just RIP my maternity leave dreams, because it took a lonely time and really exacerbated it.
Right.
It was really, really difficult. Yeah. It's a great other podcast topic for.
Yeah, like babies, like the experience of having a baby during the pandemic. That's really unique. And a lot of people, I mean, I don't know. I read something today or yesterday that some of the birth rates were lower or expected to be lower, but there's still millions of babies being born. Mm-hmm. So there's a lot of people that had that experience, that very unique experience. Mm-hmm.
Yeah, and it's just, this is another societal thing, but just society's expectations of women returning to work and when I say society, I mean American society, their expectations on professional women and just working women of what they can do with a baby, and even all the parents who had children and they were expected to work during the pandemic and watch their children. And I know from the quote unquote mom guilt of even trying to work when she's home for the evening and, I'm walking past her because I'm trying to have a work call or respond to emails, and people were doing that all day. And so it just really exacerbated expectations there. And, there was all these articles and everything like women are superheroes. They're taking care of their kids. They're killing it at their jobs. And they're not. That you can't do that. You can't super succeed at 3 full-time jobs at the same time, and setting up that expectation is disrespectful to feminism. It's disrespectful to women. You think you're being very pro-feminist by saying that you're empowering women, but really you're just setting up a ridiculous expectation that's going to make every woman feel like she's failing.
Right, because you can't do all those jobs. You can't do all those jobs well.
No, not at the same time. You just
can't.
Not
at the same time, right?
Yeah.
Wow.
It's another passion, so we can talk offline about that.
Yeah, let's. All right, let's stop recording and we'll talk about that some more. So I want to thank you on the record for being on the podcast.
Thank you so much for having me.
Thanks, Wendy.